Silverman is going to make his second part of this session of today. Is going to start today about the single ventricle physiology, and then he's going to continue on next month, and then he's going to have a couple of weeks of vacation, and for sure we are going to restart in September his series as well. So now he's going to talk to us about functionally single ventricle, and you can find all of these amazing images on this website. That's his book. You can get every chapter. I have all of them. They are really, really amazing. So take a look at www.md1more.com, and there you're going to find this book chapter and the other book chapters that he has done so far. And now with you, Dr. Norman Silverman.
Thank you very much, Grace. I hope you can all see my screen.
Yes, we can.
The topic for today, as Grace had mentioned, is the functionally single ventricle. And as Grace had mentioned, you can find this on our Congenital Heart Academy. Today's session is recorded, and also with commentary and greater expansion of cases at md1world.com. So the functionally single ventricle, the definition is it describes a spectrum of congenital cardiac malformations in which the ventricular mass may not readily lend itself to partitioning that commits one ventricular pump to the systemic circulation and another to the pulmonary circulation. And of course, what's not in the definition is how we treat these patients. And I think that we all know that there are patients which we cannot use two ventricles, and that usually involves a series of maneuvers that leads to a Fontan procedure as the ultimate surgical treatment that we can do for these patients, besides transplanting their hearts, should that be necessary. Now, today, we're going to discuss double inlet ventricle and tricuspid atresia, and on July the 12th, we'll discuss these other topics, and I hope you'll tune in for that. Now, we begin here first by describing this great experience from Dr. Thomas Peacock, called Cases of Malformation of the Heart, where both auricles open into the left ventricle and transposition of the aorta and pulmonary arteries was present. And this was published in the Transactions of Pathological Society in London in 1854. The drawings have been matched here with some specimens from our archive. And so you can see that when Professor Anderson did these pictures, that he actually looked at exactly what Peacock had done and showed here a morphologically left ventricle with fine crisscrossing apical trabeculations and a smooth upper border. The heart has been opened in clamshell fashion, and we see the inlet into this left ventricle and an outlet through a interventricular communication, which has sometimes been called a ventricular septal defect, but Professor Anderson has insisted we call it an interventricular communication, which is much, much more appropriate embryologically. And then when we look at the outlet here, as Peacock's original drawing, showing the aorta arising from this little outlet chamber, and here is the aorta arising from the outlet chamber. And how do we look at these patients? Well, we look at them by means of pathology, and here's the heart cut in clamshell fashion with the front end open, showing the aorta from the morphologically right ventricle, the incomplete right ventricle, and the pulmonary trunk from the left ventricle. Here is a three-dimensional printed volume cast showing the classical position of this functionally single ventricle, with the left ventricle connected to the right atrium, the inlet from the pulmonary, from the left atrium also into this chamber, an interventricular communication with incomplete right ventricle and aorta. And these can be also looked at by means of here micro CT And also on the basis of angiography, with here is the double inlet into the morphologically left ventricle, the interventricular communication, and the incomplete right ventricle, as you see it here. And lastly, the echocardiographic features, which show again double inlet into a morphologically left ventricle with the pulmonary artery arising from this ventricle. And then if we come a little bit further forward and we scan in a cranial direction, we can see the inlets into the ventricle, the double inlet ventricle, the interventricular communication, and the aorta arising from the outlet. So how do we approach this? Well, first of all, using everything that Dr. Anderson has expressed in terms of establishing the position of the heart within the chest, following sequential segmental analysis of the cardiac segments, which usually shows the establishment of the veno-atrial arrangement, the atrial arrangement itself, or what is used to be called situs, describe the atrioventricular connections, either as double inlet, absent left or right connection, common atrioventricular valve, or straddle, and describe the ventricular morphology, topology, and position, determine the morphology of the dominant ventricle as left, right, or indeterminate, and the morphology of any other complete ventricles, describe the ventricular arterial connections, and describe the course and relation of the coronary arteries, and finally describe anomalies of the great arteries. So this is a complex group of patients and requires a complete examination. So what we'll look at first is double inlet ventricle and demonstrate the various views needed to define these disorders. And I'm going to start off and use this format for the rest of this presentation. Here is the echocardiographic cut superimposed upon specimens, and eventually here is the echocardiogram. So these echocardiographic cuts will be removed, and then you can see the morphology with the labels on showing double inlet into a left ventricle, an interventricular communication, incomplete right ventricle, and aorta. And we can see this here with morphology. I've matched this as well with a CT scan from Dr. Tony Lavacek. And also you can see here on the echo the same features. The pulmonary artery, of course, in this particular example is different in that it is small and there's stenosis. And here is the aorta, which is large, coming off the incomplete right ventricle. So then we'll remove all the labels. And then with the labels on, we will show the motion of the heart. And when you've received that, we will take them off. And then we will zoom in so that we can see these anomalies more clearly. And I'll be doing that on all of the subsequent slides. So the morphologically left ventricle is connected to the pulmonary trunk. There's the interventricular communication, and here's the aorta arising from the incomplete right ventricle. Now, so long axis is very useful. The short axis is extremely valuable. And here I've shown a short axis coming through the level of the great arteries and displayed three great arteries with aorta anterior and leftward, pulmonary artery posterior and rightward. Here I've shown that there are anomalies of the AV valves. Here's an example of a partially fused pulmonary valve leaflet, which is stenotic. And also we're looking at the coronary arteries, and we can see here from this aortic route, we see the coronary artery, the left coronary artery, dividing into left anterior or interventricular, anterior interventricular artery, and the circumflex coronary artery over there. And I will take the labels off sequentially on all of these things so that you can appreciate the echocardiograms in their fullest, and then I will zoom them up so that you can see this, perhaps if you're looking at this on your iPhone. Now, when we look down a little lower, we can see here the great roots. I've imposed this, superimposed this on a specimen. The interventricular communication will always be as green as a sort of a cylinder. And here is a short axis once again, showing a stenosis of the pulmonary valve leaflet. and also the whole main pulmonary artery. And then after a position of the stent, we can see the improved flow into the pulmonary trunk from this particular example. So you see very nicely the stent lying within the pulmonary trunk here. Now we move the probe down a little further towards the level of the ventricles, and now we can assess the position of the atrioventricular valves, the right AV valve and the left AV valve. We don't call them mitral and tricuspid, although sometimes we might slip and call that there. And here's the morphologically left ventricle, and clearly shows the features of a double inlet ventricle with the descending aorta seen behind the heart to recognize the size of the plane. So I think you can see double inlet very clearly in this example without an intervening interventricular septum. Now we can also look at the size of the AV valves in short axis. And here I've superimposed this on this echocardiogram. And you see, I've showed this slide a few times, the hypoplasia of this right atrioventricular valve, orifice and valve. Here's the coronary sinus and the oval fossa. And here on the echo, you can see the two atrioventricular valves, and unfortunately, they are not always of normal size. So here's a normal size, the left AV valve in the morphologically left ventricle, and the right AV valve is tiny by comparison with sort of redundant tendinous cords flipping around here. But the orifice of the valve is really much smaller. Sometimes the ventricles may be indeterminate, as this one is, this very trabeculated. You think that maybe this is a right ventricle, but it doesn't have any clear features of a right ventricle. Here, the scan plane is going through the common atrioventricular valve, and you can see the pulmonary and aortic outflow from this ventricle bounded by muscular infundibulums on both sides. And of course, when we echo these patients, we're looking here at primarily the common atrioventricular valve orifice in this indeterminate ventricle here. Now, I've taken this again from the Peacock first demonstration to show apical four-chamber cut. And there are two images put in here, and we see both the right and left atrioventricular valve orifices draining to the morphologically left ventricle with its fine crisscrossing atrioventricular trabeculations. And this compared to the cut that we see here, and you can see as we put this in motion that there are other things that are important. The AV valves are lying on the same level, because there's no offsetting because of the development of the septum. The right AV valve orifice and the left AV valve orifice are of reasonable size, but both demonstrate AV valve regurgitation more marked on the left side than on the right side. Now we can look at this with a variety of techniques, and here is another example of a micro CT and a four-chamber cut courtesy of Tony Lavacek. And you see the double inlet into the ventricle, the inferior buttress of the atrial septum, and the junctions both of the left and the right atrium into this morphologically left ventricle. And once again, we show this here. And of course, there's a bulging of septum primum, the primary atrial septum here. Here's the pulmonary veins, and identifying this as left atrium, the veno-atrial connections. And the atrial septum is bulging because in this particular condition, there was not diminished pulmonary blood flow, and there was a marked increase in the pulmonary systemic flow ratio in this patient. Now, another double inlet from the subcostal coronal cut. And here are two ventricles showing the fine crisscrossing apical trabeculation. Here's the position of the subcostal coronal cut, and the plane is going to move upwards and downwards in this in a series of pictures. So this is a sweep rather than a single plane. So once again, the morphology, there's the inferior caval vein, the right atrium, left AV valve, right AV valve, morphologically ventricle. And this courtesy of Andrew Cook in London from a fetus with a double inlet left ventricle. And this is the morphologically left ventricle. Here are the pulmonary veins and the great vessels and the tracheobronchial tree behind here. And then, of course, we will move this in motion and look at what we can do with the scan, moving it more from a caudal to a cranial direction. And I'm going to stop this picture now, and I'm going to go back to the beginning of the sweep and show you there's the double inlet into the left ventricle. Now we look and we start to see the interventricular communication. Then we follow the left ventricle into the pulmonary trunk, the interventricular communication, the incomplete right ventricle. And finally, when we come up cranially, we lose the interventricular communication. We see the bifurcation of the vessels. It looks like there's a large arterial duct present here. And then as we come forward, we can see the aorta anterior and leftward of the vessels with the small incomplete right ventricle and the left ventricle posteriorly. So putting that into play, for those of you that are looking at that on the phones, it is expanded. And here's another example showing the subcostal coronal cut with a comparison to a CT printed model, MRI printed model. And here again are the same features. You can see the interventricular communication. I'll remove those labels for you. And here is the another subcostal coronal cut with the superimposition of color flow across that. And you can see that there's some narrowing of this interventricular communication, which usually portends a presence of aortic root abnormalities. You can see here the first branching vessel is the innominate vessel. So this is a left arch, as they usually are in this condition. Now, as we see, here's an example of a subpulmonary obstruction. Here's the interventricular communication. There's some muscle in the outflow tract. The pulmonary artery is of good size, and as you can see from the cut here, is posterior to where the aorta is situated, anterior to the right. And here we'll look at the echocardiogram moving with the interventricular communication, the double inlet into the left ventricle, the interventricular communication, and incomplete right ventricle. And when we superimpose color on top of this image, we can see the subpulmonary obstruction, which is occurring here. I'll take the labels off for you so that you can see acceleration of flow in this area and muscle encroaching upon the infundibulum, just as it does here. I beg your pardon, the left ventricular outflow tract and the aorta. So Doppler color flow is extremely valuable as an imaging adjunct in this condition. And lastly, we look at the great arteries. And as you see, when the incomplete right ventricle is small and there is decrease and a lot more pulmonary blood flow with decrease in the aortic blood flow, the aortic arch develops poorly, and a coarctation is present and displayed very beautifully on the echocardiogram as well, showing the large patent arterial duct here and the transverse aorta innominate vein, and then the area of the aortic coarctation is identified as well here very clearly on the Doppler color flow and as well on the two-dimensional image as well. Now, as far as the atrioventricular valve is concerned, there are a number of anomalies, including hyperplasia, straddle, stenosis, insufficiency and atresia. And we'll go through this in the course. Here's that same picture showing the hypoplastic right atrioventricular valve. I've called it a small tricuspid, but it's a right AV valve. And you can see when we put this in play, a disparity in the size of the atrioventricular valves. And this can be quite profound. And as you see here, you almost can't see that there is a separate atrioventricular valve. But when I take the labels off, you can see that there is cordis tendineae going in here, and that this is a small hypoplastic ventricle with a small inlet into this left ventricle from this double inlet ventricle situation with hypoplastic annulus. Now, this has often been confused with by angiography and echocardiography, if you don't see this, with tricuspid atresia. But obviously, if there's double inlet into this ventricle, here's a papillary muscle supporting this. This is really double inlet ventricle with a hypoplastic orifice. As far as treatment is concerned, the treatment is identical. Now, straddling of the valves is another issue. And here we can see straddling of the right atrioventricular valve across the interventricular communication with a small hypoplastic morphologically right ventricle and a large AV valve. I think in this situation, we would give the right AV valve to the left ventricle and call this double inlet ventricle with mild straddle of the AV valve. And here is such an example of that condition here. Here's this trivial little chamber that has no connection, and there's a double inlet into the morphologically left ventricle. The atrial septum is bulging on account of the increased pulmonary blood flow. There's the descending aorta. You can also see pulmonary veins draining into that structure to establish the veno-atrial nature of this condition. So there's a zoom picture. All of them will zoom up for those of you looking at this on their smartphones. And here is a more extreme example. You can see the right AV valve is straddling into this morphologically left ventricle through a large interventricular communication. The pulmonary artery is arising from this. The aorta is coming from the incomplete right ventricle. And here are two such echocardiographic examples. First, with the valve straddling and attached to tendinous cords on the crest of the septum and in the ventricle. You see the tendinous cords coming across here. And they usually go with the cords of the left AV valve into papillary muscles situated here. And a more extreme example of this, showing here the valve not only straddling, but overriding completely the ventricular septum. And you can see the tendinous cords as I remove the labels of this AV valve draining into the morphologically left ventricle. Notice the large coronary sinus. So straddling, another important information. Now, what does straddling look like? One of the key features of straddle is the malalignment between the ventricular septal crest and the atrial septum crest. You can see that these structures are at 90 degrees to each other. And what you do when you look at the AV valve from the left atrium here, you can see what almost looks like a AV septal defect. It's not an AV septal defect, it's a straddling of the left AV valve, and this is the annulus of this valve. And if you look through the atrial septum, you can see the tricuspid valve below that as well. And if we take this heart and we turn it over and we look from the right side, you can see the tricuspid valve here. You can see this large papillary muscle. You can see the mitral valve, which is attaching in here. The position of the ventricular septum is at 90 degrees to the position of the atrial septum. And so when you echocardiograms on this patient, what you see is what looks like a classical feature of an AV septal defect. Indeed, this is not an atrial septal defect. This is really a straddling of the left AV valve. And I'll show you the other images that will prove that to you. You cannot see the atrial septum because the atrial septum is malaligned. So it looks like really an ostium primum component of an AV septal defect, because the septum is not seen in this plane. It lies at 90 degrees to this plane. And here is a zoom of showing that example of this issue. And of course, it cautions you that not everything that has an overriding valve is an AV septal defect. It just happens to be the exemplar of a straddling valve. Now, here's another picture from Diane Spicer's collection, showing again the septum, the override, and here you can see very beautifully a separate orifice from the atrial septum. Here's the atrial septum malaligned to the ventricular septum. And you can see the tricuspid valve draining the right atrium with its pectinate muscles surrounding the entrance of the AV valve. And here is the same heart cut from a different perspective, showing the exposed right ventricle. There's a pulmonary artery band on the pulmonary artery. The aorta is coming from the left ventricle. And here is the straddling valve coming across the interventricular communication and inserting with the right atrioventricular valve into a single papillary muscle here. So take the labels off so that you can appreciate this. And now let's look at the echocardiogram. And here we're going to see the straddling valve straddling across the ventricular septum. But watch over here, there's another atrioventricular valve draining into the right atrium here. And this is the same patient as on the last echocardiogram. So I'll take the labels off and I'll zoom this in so that you can see it. But here's a separate AV valve. And here is the left AV valve straddling across into this large right ventricle. The left ventricle has two closely spaced papillary muscles, just as it does in an AV septal defect. But the left ventricle has only this as the entrance here. And there's double outlet as well from the right ventricle as well. So complicated anatomy, but I think clearly defined pathologically and echocardiographically. Here's another example of a straddling valve, and you see here the valve is straddling across the ventricular septum. It's attached to papillary muscles that it shares with the left AV valve. Okay, and there's the outlet septum here with the aorta arising from the incomplete right ventricle. And another example showing more override of this vessel, but clearly with straddle, with papillary muscles support from the left ventricle. And I think the important thing about this condition is that echocardiography is the best test for recognizing this, because with MRI and CT, these things tend to be disregarded because they are a summated image. Also note beautifully the two coronary arteries arising from the aorta, which is connected to the morphologically left ventricle. Now I'll zoom that in for you so that you can get a better look at that. And here you see the valve would more or less give the straddling valve to the left ventricle. And this one maybe as well, but I think that this valve clearly has got support structures here to the morphologically right ventricle and the morphologically left ventricle. And lastly, here's another example from Dr. Spicer. This has been sliced in half. So this is the front half of the specimen, which isn't particularly helpful for us, and the back half, which shows the interventricular septum, the straddling of the left AV valve across the interventricular communication, and the right AV valve draining into a ventricle of left ventricular morphology, of right ventricular, I beg your pardon, of left ventricular morphology. I was correct. And here you can see the echocardiogram showing the straddle and the papillary muscle lying in here. There's also posterior deviation of the outlet septum, narrowing the outlet from this morphologically left ventricle, and the aorta arising from the incomplete right ventricle. So another example of straddle, and of course, very important because that is clearly something that does not permit septation of these ventricles, even if they were theoretically possible. Now, here's an example of hyperplasia of an AV valve, and there's a small left AV valve seen here. There's the right AV valve, double inlet into morphologically left ventricle, and incomplete right ventricle. And here we see the echocardiogram, which shows, I've zoomed in on this very quickly. You see the small left AV valve orifice. You can compare the size of the funnel of the jets from the left and right AV valves into this left ventricular morphology double inlet situation. And of course, we can always stop this. And here is the black and white image showing the difference in the entrance of the ventricle on the left, from the left atrium, and from the right. You see how much larger this is. And when we zoom in and look at the color, you can see the difference between the sizes of the funnels and also the acceleration of blood velocity as it goes across here. And lastly, when you see a valve that looks like this, where it's narrow and it's not a funnel but a tube, you should suspect that there's a presence of what is called a supravalvular ring. And I'll show you some examples of that in the next slide. So here we are looking down on the left AV valve in this patient with double inlet. Here's the atrial septum. There's a supravalvular ring here. There's also been an excised quadratum here. And so you can see that this ring is not actually supra, but is intravalvular in its origin, as this is the commonest expression of this lesion. And it's a sort of crescent in this patient. There's the orifice of the valve. The orifice is small, and if you were able to put your finger on this, it would be like a ring on your finger. When you got the valve into the funnel of the finger into the funnel of the valve, the ring would be on your finger in the position where a ring could be placed. And here is the same heart taken at another time, showing the right AV valve orifice and the left AV valve orifice here. And here you see the double inlet into this morphologically left ventricle and this parachute mitral valve, which has attachment from a solitary group of papillary muscles into the morphologically left ventricle. And here is the echocardiogram, which shows the supravalvular or intravalvular ring, as it is more appropriately called. As you can see, you have to have a high index of suspicion because they may be small when you initially see them. And of course, the atrial septum is bulging because there's increased pressure to get pulmonary blood flow back across the left AV valve. Now, an incomplete right ventricle and interventricular communications. This incomplete right ventricle can be right-sided, left-sided as it usually is here, or right side as it is on this example. And of course, so here is the chamber on the left side of the heart, and here is this incomplete right ventricle on the right side. Both of these are associated with a discordant ventricular arterial connection. So I'll just put that into play, remove the labels so that you can see the beautiful morphology. There's the aorta arising from the incomplete right ventricle to the right of the morphologically left ventricle. And then we'll just zoom that in for you so that you can see this beautiful example of a left-sided outlet chamber and a right-sided outlet chamber. Both have a morphologically right ventricle. Now, the interventricular communication may be restrictive. When it's restrictive, the arch is usually small and associated either with coarctation, hyperplasia of the arch, or an aortic arch interruption. So there's two planes here. They are subcostal, sagittal, and coronal. And I'll take the labels off so you can see the interventricular communication. There it is in black over here. A very small right ventricle, a small aorta, and vessels to the head and neck seen here. And here is the echocardiographic comparison. There's the interventricular communication. You see how small the outlet chamber is, and the aorta is small as well. And if we take this heart and turn it around 90 degrees and look at the subcostal sagittal cut, we can see as we pass through the great vessels that there's the classical V of the aortic arch interruption. Here's the subclavian artery coming off the descending aorta, and the ductal arch from the pulmonary trunk coming from the morphologically right ventricle. So here's the small incomplete right ventricle. Here is the two vessels, the head and neck, and there's the third one. So this is a type B aortic arch interruption and the descending aorta. And let's zoom in on that so we can see this as clearly as possible. Small left-sided aorta. There's the aorta, the head and neck vessels, the brachiocephalic and the carotid, and the space between the carotid and the subclavian, which you can see nicely on the Doppler color flow system, can be identified here. Giving an example, there we go. There's the subclavian artery and the two vessels. You can get an idea from the scale that there's a 2.5–3 centimeter distance between the left subclavian and the left carotid artery. Now, we showed this slide before, but I show this now to show you how the restriction of the interventricular foramen is important, because it's often associated with arch anomalies. And here you can see the position of that interventricular foramen. You see shown you this before, but let's concentrate on what happens here. This is a small interventricular communication. And when you do a Doppler signal on this, you can see a picture here from the reference image through the ventricular septal defect, showing a high velocity of 34 millimeters of mercury across the outlet from the interventricular foramen. And that often, about 50% of patients in our series, is associated with aortic arch anomalies. Now, we'll look at the pulmonary obstruction, because not only may the aorta be obstructed, but the pulmonary artery may be obstructed as well. And this heart has been opened in clamshell fashion. There are two different images here, in a parasternal long axis and a subcostal coronal picture. And here is the two of them. And here you can see the heart is open in clamshell fashion. So this was the left ventricle. This obviously came around over here. And then between the AV valves, you can see where the pulmonary artery is situated. And there is the pulmonary valve. And this is all subpulmonary membranous obstruction. On the outlet is the interventricular communication, which is augmented in its size because of the cut, and the aorta arising off this chamber. So we're looking at the pulmonary outlet over here. And here is the apical four-chamber view showing the pulmonary artery above. And here is the pulmonary artery coming from the morphologically left ventricle through an area of narrowing, which is tubular and very complex and and almost impossible to remove surgically. And then on a parasternal long axis, you can see the subpulmonary obstruction from the morphologically left ventricle, the posterior deviation of the outlet septum, and there's a long tunnel which is going to be extremely difficult to remove if it was just that surgical problem. So we'll zoom in on these, and I think you can see very beautifully in both of these examples the long extended views of the septum. And it's not a solitary single issue, but it's a complex issue of septum and fibrous tissue within the outlet. Now, double inlet left ventricle with incomplete right ventricle and normally related great arteries is the Holmes heart, and I have several examples of this. This is the original Holmes heart, which exists in the museum in Montreal, and was in Maud Abbott's original correction. And this is the drawing that was done of the original Holmes heart, which actually is very interesting because it shows the superior vena cava flow in white coming into the tricuspid valve, and then it goes through into the aorta coming from the left ventricle and the pulmonary artery coming from the right ventricle. And here is the right AV valve with this green flow going up through the interventricular foramen and into the incomplete right ventricle, which then drains into the pulmonary artery. The aorta is above this and transected in this particular pattern. And here is an example on echocardiogram of the Holmes heart. I've shown you this picture before, but the great vessels are normally related. Okay, so the aorta is arising from the morphologically left ventricle and the pulmonary trunk from the morphologically right ventricle. And there is double inlet. Here it is difficult to see the left AV valve. I'll direct your attention to the arrow, and you will see that there are two AV valves there. There's one here and one here, draining into this ventricle of left ventricular morphology. So there's double inlet, and the aorta is arising from the left ventricle, and the pulmonary from the incomplete right ventricle. Here's another example of the Holmes heart, and you can see from the subcostal position on the inlet of the heart and the outlet of the heart, the various features. There's clearly double inlet left ventricle. Here is where the interventricular foramen is, and the aorta is up here. Okay, so we're looking at the inlet here from the back of the heart in clamshell fashion. And now we're looking at a windowed position in the same heart of the right ventricle, and you see the interventricular communication and the pulmonary trunk clearly arising from this incomplete right ventricle, which has got a lot of ventricular hypertrophy, presumably because of this large vessel. This is not a baby heart, and there was a development of pulmonary hypertension in this patient. And here, through the interventricular communication, you can see that there is a tricuspid valve which is connected to the left ventricle. And here is that two AV valves. Here's the right AV valve from the right atrium, the left AV valve from the left atrium. Here is the aorta defined by the coronary arteries and the vessels to the head and neck. So this is double inlet left ventricle with concordant ventricular arterial connections. So there's the aorta and the arch over there and the coronary. So this is definitely an aorta. And you see the two valves kiss each other in diastole as they open all into this ventricle of left ventricular morphology. Beautiful example of the coronary arteries, with the right being lower than the left from subcostal cut. And the outlets of this look very much the same. So this looks very much like tricuspid atresia from the outset. Here is the little outlet with the little interventricular communication going into the pulmonary trunk, and here is the echo. The only issue here is that in Holmes heart, there are two AV valves draining into the morphologically left ventricle, and in tricuspid atresia, only one. And we'll get to discuss more of this comparison when we see tricuspid atresia. Here's an example of the morphologically left of a double inlet right ventricle. Inlet, let's just take the echo cut off over here. And you can see this muscle bar, which is fairly characteristic, with coarse apical trabeculations, okay? And the two AV valves draining into the right ventricle. And here is an echocardiographic example of the same. And this is a hypertrophied, very heavily trabeculated ventricle. Now, one of the easy things about saying about this heart is that it's a morphologically right ventricle is when we get to look at this over here in this patient, and I'm going to stop this echo to show it to you here, because as we begin here, there are two ventricles. Here's the morphologically left ventricle. Here's the double inlet into the right ventricle. Okay, so that's the left inlet. And as we go further on, we can see the right inlet here. Here's the left inlet, the right inlet, and double outlet from the ventricles, and a pulmonary artery band placed across the pulmonary artery. And so this again is another sweep where we start from below and see the two ventricles, that this is the morphologically left ventricle, this is the morphologically right ventricle. There are two AV valves that are draining into this ventricle, and there's also double outlet from this morphologically right ventricle. And this is a condition frequently found in isomerism of the left atrial appendages. And now this is the back of this heart. And here you can see, I'll take the echo plane off because there's only one. And you see this is a morphologically left ventricle with a smooth upper border and fine crisscrossing apical trabeculations, and just a little bit of the left AV valve straddling across and attached into a papillary muscle. And here we compare that to the echocardiogram. I'll put that off, and you can see this tendinous cord going into this little left ventricle in the hip pocket of the cardiac mass, and the right ventricle with the double outlet and the pulmonary artery band. The same picture that we've shown you, a different projection of the same echo we showed in the previous example. And look at the stenosis on the pulmonary valve in addition, not enough to band the pulmonary artery blood flow effectively. And of course, we shouldn't forget to mention that mirror image atrial arrangement and dextrocardia is a common presentation. And one of the important issues about this that I haven't discussed is the position of the heart in the chest in congenitally corrected transposition. It usually lies midline, so that the apex of the heart is frequently found in the subcostal projection. Here is a heart where the morphologically right atrium is connected to the morphologically left ventricle, and then to the pulmonary trunk, and the morphologically left atrium to the incomplete right ventricle, to the aorta. I'll take the picture off so that you can see that definitely the case. And then, of course, in that situation where you are subcostal, as we are here in the coronal cut, the apex points to the right. Here we can see the superior and inferior vena caval connection to this atrium of right atrial morphology, draining into a morphologically left ventricle with double inlet also from the left atrium, which has also been recognized by a variety of reasons. So double inlet left ventricle in mirror image dextrocardia. And as we come to the outlet, you can see there are two AV valves, and between the AV valves is a narrow entrance into the pulmonary trunk and its continuation into the left pulmonary artery. So double inlet ventricle with a mirror image arrangement of the atrial appendages and dextrocardia. And here's another example, and Dr. Anderson likes to call this the hip pocket left ventricle. This was a series of trousers, this would be at the back, your so-called hip pocket. And so here we can see the a morphological example with the interventricular communication, double inlet into the right ventricle and double outlet from the right ventricle as well, and an angiogram which shows the same and the interventricular communication, and also that seen just on the echocardiogram as well, the interventricular communication between the incomplete left ventricle and the right ventricle in a subcostal coronal cut, which I've oriented in a position that allows the comparison. Here's once again is that incomplete right ventricle we showed you, I beg your pardon, the univentricular connection to an indeterminate ventricle with a complete AV septal defect, I beg your pardon, complete atrioventricular valve, and the bilateral muscular infundibuli and the echocardiogram, which I've shown you before. I'll just play it quickly and zoom it up for you. So there's the comparison of the inlets. Obviously, this is a three-dimensional cut, so we can't see the development of the aorta and pulmonary trunks in this condition. And lastly, Here is a double inlet to a solitary indeterminate ventricle, which both has double inlet and double outlet. So here is a ventricle whose morphology cannot be adequately determined. There's double inlet into this ventricle. There's a little muscular bar here, which is frequently present and does not indicate the ventricular septum. And here is double outlet into the aortic and pulmonary trunks over here in this example. Now, absent connections. Univentricular connections may have no connection between the atrium and the ventricle. And when this occurs on the left side, we often term this mitral atresia. When it occurs on the right side, it's termed tricuspid atresia. The following examples of these echocardiographic morphological correlations. And you see here very beautifully on this glass body from Andrew Cook, the left atrial appendage and the left atrium and the underlying left ventricle, and the absence of a connection between the left atrium and the left ventricle. There's a large muscular ventricular septal defect. And so the blood flow in utero could go from the right ventricle into the left ventricle and out into the aorta, but was somewhat restricted. So the aorta is small, gives rise to the vessels, the head and neck, has a very small isthmus, and obviously a coarctation of the preductal variety at this particular junction. The right ventricle is connected to the right atrium. There's no other AV valve here. And the right ventricles continue to the pulmonary trunk, gives off the branch pulmonary arteries that you can see right and left over here, continues through the ductus and into the descending aorta. Now we're going to concentrate on the echo only on this feature here, because that's the important issue that we're discussing at the moment. And there's the left atrium and the underlying left ventricle. There's an interventricular communication and a large right ventricle. So here's the right atrium, the left atrium, I beg your pardon. And there's the underlying incomplete left ventricle. And there is no connection. And there is the right AV valve over here. Interventricular communication. Let's just zoom this in quickly so we can make that comparison when we're highlighting this particular area. Now, we have the condition where the right AV valve is atretic, and that's tricuspid atresia. There are several types that we all know about from the Edwards and Burchell classification, where they call this a tricuspid rather than a right atrioventricular valve. And there are three types. Type 1 with normally related great vessels, type 2 with detransposition, and type 3 with congenitally corrected transposition. And this one where there's a closed ventricular septum, the usual type with a small interventricular communication and a pulmonary stenosis, and a moderately large VSD with subpulmonary stenosis, and then the types associated with transposition. So we need a full complement of views. We have to check for everything as we've described for the functionally single ventricle. So let's get on and look at tricuspid atresia. And you see here now in tricuspid atresia a slice that compares to the echocardiogram, not quite, but you see how small the right ventricle is in this mass of right ventricle. Here are subcostal, coronal, and sagittal plane cuts. There's the pulmonary trunk and the aorta. So the pulmonary trunk is not shown, is connected to the aorta here because the cut is a little too anterior. There's the left atrial appendage. There's the left ventricle over here. And here you can see the characteristic features of tricuspid atresia, which is an absence of the connection between the right atrium and the right ventricle. Note the space here at all. So there's no ventricle. And then the echocardiogram, you can see this little interventricular communication leading into a diminutive ventricle. The ventricle arches over the aorta, so we don't see the connection to the right ventricle here. Let me just put this now in a cut there. There you see that very beautifully, the inlet and the outlet into the pulmonary trunk with the bifurcation there. And I'll take that off now. And when we look in the sagittal plane, in the same patient, in the opposite direction, we see the diaphragm, the anterior chest wall, we see the right ventricle. We don't see the right atrium, but we can see the outflow tract in this ventricle. The flow is coming from the interventricular communication, and there's a hypoplastic infundibulum leading into a main pulmonary artery. And also note that there is a patent arterial ductus because there's diastolic flow into the pulmonary artery from this patent arterial ductus. Patent arterial duct. Now here's another example, a beautiful example of tricuspid atresia. And note again the fundamental, the absence of the connection between the right atrium and the underlying right ventricle, or ventricle, incomplete right ventricle. Here's the right coronary artery running in the groove, giving rise to its various branches. And you can see that the aorta is arising from this chamber so that there is transposition. And of course, the ventricle in this situation is a little larger than in the usual situation. Now, what I've done is I've shown you the value of contrast echocardiography in this condition. And here you can see right and left atrium from a transesophageal probe position. It gives rise to a 4-chamber projection. So we've got right and left atrium, incomplete right ventricle and left ventricle. And a flush of saline was done to flush through the medications, and we track this through the heart. So you see it first arriving in the right atrium, then it crosses the atrial septum, goes through the left AV valve, and then crosses the interventricular communication into the complete right ventricle. And so I'll let you look at that once, twice, and we'll zoom in on this, I hope. And now I'll stop this for you. And so we can examine all of these things as they occur in series. There's the control. Here comes the flush now. There's the bolus. It's now in the right atrium. And the next beat is much more extensive. There's the bolus in the right atrium. Crosses the interatrial communication. It's in the left atrium and the left ventricle, and in diastole has started to come across the ventricular septum, and there it completely fills the heart. So I'll let you look at that just one more time to see the value of this at defining flow dynamics with contrast echocardiography. Now here's a 4-chamber cut showing again the absence, the essence, the absence of the atrial septum. This is the Eustachian valve over here, and this is the interatrial septum primum. Here's the superior buttress of the atrial septum. And here's the echocardiogram, which shows the atrial septum bulging into the left atrium and the small interventricular communication, and the absence of the connection between the right atrium and the morphologically right ventricle, with a lovely Eustachian valve being present in this heart as well. When we look down on the right atrium, the open right atrium, you'll often see this little dimple in the region of the right atrioventricular valve where you'd expect to find it. Here's the oval fossa, here's the coronary sinus, so we're in the right place. This is where we would expect to see it. And on another picture, Dr. Diane Spicer has put a probe across this. Here is the incomplete right ventricle. There is absence of connection between the atrium and the incomplete right ventricle. And this probe in this area goes into the morphologically left ventricle. And here is an echocardiogram showing a scan in this position. I don't know why it didn't move. There we go. And here is the pulmonary artery and the aorta arising from the left ventricle. There is a divided left atrium, so-called porta atriatum. And you can see here that the outflow from the left ventricle is going to the right ventricle through the interventricular communication. We can see this even in the fetus. And here is a fetal example from Dr. Andrew Cook, which shows the hypoplastic incomplete right ventricle even in a fetus. And a cartoon from Professor Anderson emphasizing the absence of the connection here. with the incomplete right ventricle, and the echocardiogram, which shows the same features. There's the interventricular communication between the left and incomplete right ventricle. You can see the right atrium and the left atrium with the septum bulging in this direction. We can see the pulmonary veins, the descending aorta, and the left pulmonary artery. And I'll remove the view so that you can see it there, and perhaps even magnify that so it becomes a little easier to see. Spine, descending aorta, left pulmonary artery, pulmonary veins draining to the left atrium, the normal left-sided structures, the interventricular communication, and the absence of connection between the right atrium and the right ventricle in this 20-week fetus. Now we'll look at the interventricular communication, starting with small interventricular communications. And here is such an example. Okay. You see the septum bulging right to left here with the incomplete right ventricle. Now we look at a larger one. Here's a beautiful example of the interventricular communication, the absence of the connection between the bottom of the right atrium and the ventricle, so no connection there, and no other atrioventricular valve. There's the left atrium and the left ventricle. And here is a subcostal coronal color compare picture showing the position of the interventricular communication in green, and I'll take that off, and you can see the black and white in color image with the flow characteristics shown across this incomplete right ventricle. Here's another example of a interventricular communication, a moderate to large size, the type 1C, seen at transesophageal in a 4-chamber plane here. And here is the absent connection with the cauda atriatum. This is the vestibule of the mitral valve. Here is the other part, which has the atrium, the left atrial appendages in this region here. And here is a very large interventricular communication for type 1 tricuspid atresia. And you see how the size of the defect can be much larger. Here is a membranous absence of the valve, a so-called imperforate tricuspid valve, seen from the right atrium. There's the coronary sinus. There's the oval fossa over here. And so here, instead of the dimple, there's sort of a membrane. And here is the formed tricuspid valve with the clotted-filled right ventricle cut in 4-chamber plane. And here is such an example of this membranous tricuspid atresia. Nothing coming across that atrial septum, right atrioventricular junction. And the outlets, we've seen this before. I'm going to move through this very quickly because we are running out of time. We're going nearly an hour and this is nearly complete. And here is the difference between the Holmes heart and tricuspid atresia. We've seen the Holmes heart before. Here's tricuspid atresia. The outlets look pretty much the same. So there really is very little difference between the Holmes heart and tricuspid atresia, which is why we call this an absent right atrioventricular connection. And here, once again, with this, we see the right ventricular outflow tract to the pulmonary trunk. And here, again, in the so-called double inlet, you can see that there is a small interventricular communication and interruption of the aortic arch. I do not have a picture for that on this particular example, but wanted to highlight the position between an outlet chamber of a tricuspid atresia and a double inlet left ventricle. Here's again the hyperplastic valve, which he showed you, but this patient was diagnosed as tricuspid atresia until it underwent a Fontan procedure. And here you can see that with color flow now, you can see a small amount of flow coming across the tricuspid valve. So not, in fact, tricuspid atresia, but hyperplastic right AV valve orifice. Now, there are many other lesions associated with tricuspid atresia, besides the usual one: common arterial trump, interrupted arch, patent arterial duct, AV septal defects, abnormalities of cardiac position, mitral valve abnormalities, juxtaposition of the atrial appendages, and many others. And here's a patient who's had the pulmonary artery band and has the aorta arising from the right ventricle, so discordant ventricular arterial connections. There's the band in the 4-chamber cut. And here is a subcostal sagittal cut showing the position of the interventricular communication and the incomplete right ventricle going to the aorta. Here's a patient with a right-sided apex. There is a usual atrial arrangement, but the right atrial appendage has gone behind the great vessels and is here in the behind and presenting on the left side. Excuse me. And you can see, in addition, there is dextrocardia, and there's only a solitary mitral valve in this patient. And I've zoomed this up for you so that you can see it in motion, that the interventricular foramen is very, very restrictive in its nature. And the aorta is arising from the left, from the incomplete right ventricle, and the pulmonary artery from the left ventricle. Now, clefts, or so-called divided anterior leaflet of the mitral valve, of the mural leaflet of the mitral valve, is fairly common. And here is a parasternal long axis view and also a short axis view showing the features of a divided anterior leaflet of the mitral valve. This used to be called a cleft mitral valve. Okay, when we wrote the paper, that was called a cleft mitral valve. And there's the tendinous cords attached to the crest of the septum. There's the mural leaflet. The anterior leaflet is clearly divided, as it is in an AV septal defect. And indeed, this condition is a sort of a form thrust of this condition. And here again, in short axis, you can see the division of the atrioventricular valves. And I'll just zoom in on this so that you can appreciate that in 1 or 2 beats before we turn it over to the next presentation. Here's another example showing the cords almost always go towards the position of the interventricular communication. This is a patient with tricuspid atresia. You see the morphologically left ventricle, and I've matched this with the short axis image to show the so-called cleft in the valve, the interventricular communication, and the right ventricle. And here's a patient with a sort of divided atrium, and this is the membrane which exists in the so-called porta atriatum. Okay, here's the pulmonary venous orifice. Here's the vestibule of the atrium, which has also the left atrial appendage in it, and the mitral valve and left ventricle. And here is an echocardiogram showing the tricuspid atresia. And with the divided membrane jetting through at this lateral edge here, and the mitral valve with an absent connection on the right ventricle. Don't forget the patent arterial duct. Here's an example showing different views of the duct. The arterial duct can lead you into a sense of false security about the saturations, because when it goes, the patients may get rapidly blue. And here you see the ductus, and you see also here from 3 different views, the ductus cut, the parasternal short axis showing the ductus entering the left pulmonary artery origin, and from the suprasternal notch, an arterial duct, a small arterial duct in tricuspid atresia. And we can just zoom in on those 3 and have you look at that for a moment. There's a shunt, and this shunt has also got a stent in it. This is a modified BT shunt into the right pulmonary artery. We don't see the left pulmonary artery. Here's the dimple of where the pulmonary valve should have been, but isn't. And then when we put the echo into motion, you see the BT shunt, you see the right pulmonary artery, you see a little bit of shunt going towards the main pulmonary trunk, but no left pulmonary artery. So an absence which is comparable between the specimen and the echocardiogram. We've done this once before to show you this little incomplete right ventricle with dextrocardia. And lastly, juxtaposition of the atrial appendages with the right atrial appendage above this long tubular hypoplastic finger-like left atrial appendage. And not only are the appendages going around this way, but the atrial septum is pulled by that. Now, because the position of these atriums are at such a different level, it is often very difficult to record them simultaneously. And certainly in this condition, I have not been able to do it, but you can see all the features here. Here's the right atrial appendage. Here's the pulled atrial septum going in the direction of the atrial appendage. And then when we get a little bit further and we look down a little bit more inferiorly, we can see the left atrial appendage within the left atrium and the atrial appendage, also the atrial septum pulled over towards the right side. So this is a common feature of tricuspid atresia and occurs in a proportion of patients and is always worthwhile looking for. And so, ladies and gentlemen, we've done this in record time. This was 75 presentations, separate images over the course of an hour, and I'm ready to try and answer any questions that may be coming from the group.
It was amazing, Norman. Thank you very much for that. It was really, really good. We have a few questions, and guys, please type your questions in the Q&A chat box. We are going to be happy to answer. So the first one, Dr. Silverman, is Dr. Carlos Troconis is asking, how do you define morphological LV?
In the usual way. If you followed any of the Anderson presentations, which are all on Congenital Heart Academy, we use the morphologic method. And the morphologic method says that you have to define a particular structure on its primary features. And the primary features on a left ventricle are defined crisscrossing apical trabeculations. So there's no coarse trabeculations. The shape of the ventricle, the presence of the continuity between the semilunar valve and the atrioventricular valve, and then the smooth upper border of the ventricle. And that's how you define it morphologically. I think it's sometimes a little bit more difficult echocardiographically, but I think in the course of this, if one were to go back and look at this, you can clearly see what is a morphologic left ventricle and what's a morphological right ventricle. So I hope that that's a good answer.
I'm sure it was. Sandra Flores is asking, the term bulboventricular foramen is not correct when speaking of a communication between a complete ventricle and an incomplete ventricle.
Look, you know, this is a problem of terminology rather than a problem of how we define it. Okay? Now, I think that Professor Anderson has shown you embryologically in the course of these presentations that the thing that we used to call a bulboventricular foramen is really the secondary interventricular communication of the embryo. And so being a stickler for correct terminology, we don't call it a bulboventricular foramen. You may call it a bulboventricular foramen, but it is indeed the secondary interventricular communication and not a bulboventricular foramen. The bulboventricular foramen was a term which was described by morphologists when they didn't have the perception of embryology in this. And there's clearly from our pictures, and I see Grace nodding her head because she agrees with me, that you can see this beautifully on any of the Anderson presentations on embryology.
Yeah, please take a look on the YouTube channel. We have amazing presentations from Dr. Anderson. Dr. Silverman was a panelist on that as well, about single ventricle morphology. You can take a look on that. And one last question, Rodrigo Berones is asking by, I think he means velocity, when do you consider a VSD obstructive or restrictive?
Well, that's a very good point, and we've written a paper on this. I can't remember exactly, it was a long time ago. Dr. Stephen Sanders from Boston and I published this almost simultaneously. But if it's less than 2 centimeters squared per meter squared of body surface area, okay, then we consider it restrictive in terms of its morphology. We consider the color Doppler will help you, as you've seen here, with 34 millimeters of mercury that I showed you on one example, clearly shows restriction. But you can't use Doppler color flow because usually there's a large amount of flow that's ejected across that area. And so that there's going to be an increased velocity across the outlet, but that doesn't necessarily mean that it's restrictive. So I don't think the Doppler color flow change of signal is important. What is more important is how far the defect exists. So you can use that as a dimension method. If you get to the jet area, you can see what is the breadth of the jet, and if you square that, you can get to the area of looking at whether it's greater or lesser than 2 centimeters squared per meter squared of body surface area. And that is indeed a very important observation. And thank you for that question.
Thank you, Dr. Silverman. We have one last question. Amina is asking, how can we distinguish between a proeminent papillary muscle and an interventricular septum?
I see the problem. I don't have that problem personally, but you know, I think it is sometimes difficult and requires multiple images to look at that. You can't just look at one particular view and say, oh, well, this is a papillary muscle. And the reason you cannot say that is because in some patients, the tendinous cords insert onto the ventricular septum or a papillary muscle. So I see the problem, but if you look at multiple imaging in different projections, you can usually recognize the difference between a papillary muscle. A papillary muscle will usually be surrounded by blood on all sides if you cut across it, whereas a septum will not. So I think that is the issue. And eventually, I think it's a value judgment. But I think in the examples I've shown you, where I've labeled it as papillary muscle, and if you want to go back and look at this again, you can see that these are clearly papillary muscles and not ventricular communications. If I've put an interventricular communication on it, that clearly is a ventricular septum.
Okay, great. Sergey is asking you, what's the best source for Z-score? Do you have a table or a chart?
Well, we're using Z-scores now. We're using the Boston Z-scores, which are available on most commercial programs. But I would like to direct the readers that if they want to see any measurements, if they go to this website, parameter Z, one word, .com, there's a gentleman in San Diego who's looked at all of the different Z-scores, and you can put all of these Z-scores on. I think it's a very wonderful service that he's done, because there are a number of people that have done different Z-scores. Okay, Z-score is really one standard deviation, and two Z-scores are two standard deviations. So if you go and look at normal dimensions on Z-scores, a 2 Z-score is 2 standard deviations, either above or below the mean. And when it's beyond that, we regard it as abnormal. So once again, the site is parameterz.com, and it would be nice if you could put that up on the website sometime for everybody, because it's a very, very valuable system and it doesn't cost money to do it.
Very nice. Good to know. And I have one more question. Fabiola is asking, is it possible to identify the septum marginal trabeculae by echo?
Absolutely. Absolutely. And you can do it in many planes. In the short axis plane, the septomarginal trabeculation runs on the right ventricle. It often makes the ventricular septum look thick. In the subcostal region, you can usually see the upper part of the septomarginal trabeculation in subcostal imaging. In the apical image, you can sometimes see it. Now, the septomarginal trabeculation is a very complicated issue. And what we found out is when the right ventricle dilates, the septomarginal trabeculation, particularly at the lower end where the moderator band exists, is that this trabeculation comes off the ventricular septum and starts to look like a separate isolated papillary muscle. And usually that's a sign of chronic right ventricular dilatation. It's a very valuable sign. So you can see it in four-chamber and you can see it in subcostal imaging, in the subcostal coronal view and the four-chamber view. And you can also see it in a parasternal short axis view. I hope that's a good enough answer.
Perfect. Thank you very, very much. We don't have more questions. Thank you guys for joining us. I hope to see you all Friday with Dr. Anderson, and Dr. Silverman is going to be a panelist as well for the second part of isomerism. And Norman, thank you very much. Your series is amazing, and we really appreciate all that you have been doing for congenital heart.
Thank you very much, Grace. And I just wanted to ask you, when is the fetal session?
24th.
24th. Okay, so that's going to be a great session. I'm going to be part of that session as well. But
very nice.
All the sessions on the Congenital Heart Academy are of such a high standard. I'm just happy that I can make into the 2 standard deviations of the Congenital Heart Academy.
You are one of our stars, Norman. Thank you very much.
Okay. Great job to Grace. Thank you. And Stasha, thank you. And goodbye.
Bye-bye. See you soon.
Yeah, Friday.